Okay, so that day we were in point number 5. I don't know whether you remember the other dilemmas or not. Should I revise the other dilemma or we'll go from?
No, sir, starting from 5.
Point 5? Okay. Now, how to negotiate with no calls, or how critical is your fetal fraction? No calls is what? Like we have given the sample for NIPT and we don't get a report, and lab regrets saying that we are not able to furnish the report. So this is a very refined way of saying that they are not able to process and generate the report in the forms of no calls. Now, once you receive that kind of report, what will you do from there onwards? That is the dilemma. So you have done a combined first trimester. I'm assuming we are into this contingent screening model where we have done combined first trimester, and then you subjected the high risk, which we have discussed before the other day, to NIPT. And NIPT came as no result. Now the option is repeat, that is redraw the blood and again give it to the lab, and the chances are in 50 to 60% of the cases you will get report. 50 to 60. Okay. The other 40 to 50% you may not get the report. Again, it may be the no calls. Second, maybe you do an invasive. You say, okay, there is chances that 40 to 50% I will not get, and when I again redraw and give, again lab tells again 10 days I will take to generate the report. So this way the gestational age is progressing. So let me just do an invasive and clear it here itself. And lab does the reimbursement for this amniocentesis which you will be doing. Or the other option is couple says, no, I am very scared about the invasive. Do some alternative screening test. So alternative screening test will be quadruple. You do a quadruple. Or you just do a good detailed ultrasound. So these are the 4 limbs of your decision making, which you will fall back when you see no calls on NIPT. Now, there is nothing called which is the best tool. It all depends upon your counseling and how patients takes it. Okay, but based on the working algorithm of the no calls, which is 3B, that is biology, bioinformatics and plan B. The consensus is when you get no calls, general assumption is the placenta is having a problem. And because of that, there is not enough cell-free fetal DNA into the maternal circulation for the bioinformatics to analyze them and to give you a meaningful report. That is the most common assumptions or explanations for that. Now, what are the causes which will cause reduced fetal fraction? That is important to identify. So aneuploidy is one, but amongst aneuploidy, triploidy stands number 1, digenic triploidy, number 1. Number 2, trisomy 18 oblique trisomy 13. Number 3, other chromosomes except trisomy 21. Trisomy 21 placental mass is same like a euploid fetus. So no calls because of low fetal fraction, you should not think trisomy 21. It does not happen. And now, once you know my first 2 or first 3 major players are triploidy, trisomy 18 and 13, and these 3 you can very well use your ultrasound tool to have some idea about it. So if in a first place you do a detailed ultrasound, you call back patient and say, look, let me check again the fetus, and you check carefully. And then you find, okay.
This is at what week, sir? You're talking about the early anatomy scan, or we call it at the normal anatomy scan?
No, early.
Early anatomy scan we call it.
As soon as we receive, like suppose we have given the sample at 12 weeks, at 14 weeks we get no calls. Call them back at 14 or 15 weeks only and just check the ultrasound. If an ultrasound you find there is some problem, you identify, okay, there is some cleft, fine cleft you are seeing, or some congenital heart disease or something, whatever. Then you are very much sure that this is some kind of trisomy 18-13 or some significant genetic problem. Then directly you do an invasive test after ultrasound. even if it requires CVS. Even if you are seeing a structural abnormality, do CVS at that point of time at 14 weeks, chalega, no issues. But on ultrasound, if you see absolutely everything is fine, there is no problem. You have checked very carefully transabdominally, transvaginally, you have spent time on that, but you don't see any problem. Then the dilemma is more, because then you may go for a redraw, just a repeat why this has happened, or there may be some placental issues which is causing the problem. And if baby is normal, please don't do the CVS. Don't do CVS, because again CVS you are sampling the placenta. You are not sampling the fetus exactly.
No.
So in those situations, either you again repeat it or tell the couple that since now it is 14 weeks or so, I think it will be a better option to do an amniocentesis after 15 weeks to make sure that fetus is absolutely normal. Okay, so despite all these decision making points, your central decision making tool will be your ultrasound. To do a good ultrasound, to triage them, which will go immediately for a CVS for confirmation, or where you can wait, repeat the sample if they agree, or do amniocentesis in that window period of amniocentesis. So these are all the decision making which you have to inform the couple and let them decide on it. But yes, you have to educate them, you have to empower them to make a decision making. And if you look at this chart, the rate of failure of NIPT percentage wise in singleton pregnancies at whatever BMI, say like BMI of 30 if you take, you look how high it is for IVF conception. So singleton, even with IVF conception, there is very high chances. And why this happens? Because of the placentation issues in IVF pregnancies. And if you move to twins, you see this even increases in IVF, 24, and in spontaneous 5. So suppose we are not into IVF category, even we are into the spontaneous, in twins it will be even higher. So why it is higher? Because the overall fetal fraction in twins is lower. I discussed that.
Yes.
Combined fetal fraction will be higher.
But considering each one.
But each fetal fraction will be around 35% lower. That is why the chances of no calls will be higher in the twins. So when you are sending NIPT sample for the twins, you have to tell them about this figure of no calls, which is higher in twins. Okay. So this is one thing. Other is when you talk about the effects of fetal fraction, this is just a scheme which I drew just to explain you. This is a bell. This is the bell-shaped curve, and in bell-shaped curve, what is bell-shaped? Is the normal distribution of anything, height, weight, blood pressure, anything which you take in a cohort of the population. If you take all together, they will form a symmetric bell-shaped, where majority of the figures will be in the midline, but then there will be some figures on the extreme side, the right side or extreme left side, there will be. But this is, however, normal, green one. And in the high risk group, if you draw, there will be, based on the fetal fraction, there will be some overlap here. So this, if you fall in this category, lab will not give you a report, because this may be in this territory of high risk, or here this may be in this territory of low risk. Are you able to understand? So this is called a no man's area. So if because of your fetal fraction, the results fall in this category, lab will not generate you the report. Now, I'll just explain you with this chart, which is very important. This is the fetal fraction. Okay. We generally prefer fetal fraction of around 8%, where your detection rate is close to 99%. But if your fetal fraction drops to 4%, 5%, you see the detection rate becomes 62%, 87%, then 62%. Though I told you last time the threshold which lab takes to generate report is 4%, but still lab will not be comfortable at 4% because the detection rate falls very significantly. So detection rate of even quadruple screening is better than 62. But false positives will be the same 0.1. So fetal fraction does not affect your false positives. It only affects your detection rates. And labs are very concerned with these detection rates, and they will not generate report if it is lower than the threshold. Now, if I move the fetal fraction a little higher, I will see a better separation of the normal and abnormal, low risk and high risk. Now, there is hardly any overlap. So, higher the fetal fraction, more will be the separation between these two, low risk and the high risk, and lab will be more comfortable in generating the report. And lower the fetal fraction, if this moves this side, there will be more and more of overlap. So this is something which we need to understand. And then sixth dilemma is how to confirm your high risk cases of cfDNA. Now you have received a case of cfDNA which shows it's a high risk. Now whether to do amniocentesis or whether to do CVS. So thumb rule is, if you don't understand anything, do amniocentesis, because you are 100% assured that you are sampling fetus. You are not sampling placenta. Okay, but if they want very early reassurance, like now in Sydney and other parts, what they are doing NIPT at 10 weeks. They are doing NIPT at 10 weeks, and they are doing a systematic transvaginal scan at 10 weeks. Based on that, NIPT sample has been given, and then they will do first trimester at 13-14 weeks, and again another prick will be done for the preeclampsia screening.
First trimester, 13-14 weeks, what is done? So only the scan part, or again the
scan part, and again they send it for preeclampsia screening.
Okay.
Okay, and NIPT they do at 10 weeks. Suppose you are doing NIPT at 10 weeks, you will get report at 12 weeks. Now if the report is high risk, then what to do? Couple don't want to wait for another 4 weeks for you to do amniocentesis. Just a minute. So in those cases, there will be a bigger challenge whether to do CVS, or because the couple will say that why not do a CVS at this point of time and clear it off. So how to make the decisions, such decisions. So this is a very conventional way of thinking, amniocentesis and CVS and their pros and cons. But the game changer is this, the risk of miscarriage. Why NIPT did such a good business is because they created a clear-cut fear in the patients and clinicians' mind by amplifying the miscarriage risk of amniocentesis and CVS. So they straight away they told that amniocentesis and CVS is having 1% risk of miscarriage. NIPT is as good as this with 99.9% detection rate and 0% risk of miscarriage. That was the highest selling point. But actual reality is, if you see all these figures, it is in the range of 0.1% as per the current consensus of the miscarriage risk of amniocentesis and CVS. And in our practice also, we have done so many amnio and CVS, hardly we encounter cases which have miscarried after doing amniocentesis or CVS. They may miscarry because of some other reasons. Their background risk of miscarriage is more than your procedure-related miscarriage risk. Any woman gets pregnant comes with a risk of miscarriage, and that miscarriage risk is higher than your procedure-related miscarriage risk. Once you explain this to the patient, suppose this is your institutional policy, you may take 0.1%, you may take 0.3%. Take little bit higher percentage, no harm in that. Somebody takes 0.5% also, that's also fine. But still it is not 1%. And once you explain the couple, most of the time, they will agree to do an invasive procedure. Otherwise, they are all scared because they have been misinformed about the miscarriage risk, and they have been misinformed about the strength of the NIPT. Because as we saw in the positive predictive value, it is somewhere close to 66 to 70%. It is not 99.9% because detection rate has got nothing to do with the robustness of the test. Robustness of the test is marked by positive predictive value of the test. Okay, So the positive predictive value is not 99%. Yes. So that we have to keep in mind while counseling our patients about the miscarriage risk. Now, abnormal NIPT report always needs confirmation by diagnostic test. Don't flush it out. Don't ask just based on the NIPT high risk that okay, you go for termination of pregnancy. That is the cardinal sin. Because we saw in that slide OAPR, odds of being affected with a positive result was 1:6.
1:6.
That means you will do 6 amnios to pick one Down syndrome positive case, 2 positive case. Whereas OAPR of combined first trimester was 1:22.
22.
That means you will do 22 cases to pick up 1 case of amniocentesis. Okay, so this we have to understand very clearly that based on the NIPT report, we will not give any decision. We will wait and then we will do a confirmation of this NIPT report by invasive test. Now, the best test to confirm high risk NIPT. Phenotype, first phenotype or genotype. So phenotype, what do we mean? We do a detailed ultrasound to identify if the fetus is normal or having any soft marker or having any hard marker. That is the structural problem. So in my experience, first thing is do a detailed ultrasound to do a deep phenotyping, detailed analysis, structural evaluation, and then your decision will be based on the phenotype, which I discussed with you in the previous slides. Why your decision will be based on the phenotype, I have discussed with you. Now, if you see this, this trisomy 21, trisomy 18, 13 and monosomy X. If you have done, these are the relative rates of the mosaicism. Okay, so if NIPT shows high risk for trisomy 21, high risk for trisomy 21, the confirmation can be done by CVS, because there is only 2% chances that it will fool you because of the placental mosaicism. Placental mosaicism I showed you in that false positive. Part or whole of the placenta is abnormal, but fetus is normal. As because you are sampling the placenta, you may get false positive. But this happens only in 2% of cases of trisomy 21. So here you can take a chance of confirmation by CVS, because you know that most of the cases it is not that case. If you get a case like this, XO, Turner's, then there is 59% chance of placental mosaicism. So a lot higher chances of only placenta being problematic but fetus being normal. So these cases you will not do CVS for confirmation, you will ask them to come in amniocentesis time frame for confirmation, because you don't want to fall in this trap of confined placental mosaicism. Okay?
But 18 and 13?
Yeah, that is the issue. Now 18 and 13.
Anatomy.
Anatomy.
Right.
Right? So there are two ends of the spectrum. Trisomy 21, you do CVS. If it is high risk for trisomy 21, ideally you should not ask them to wait for amniocentesis. You can do a CVS. People may argue, but this is based on the very robust data which I am quoting. So you can do that. And
So
if it is sex
abnormality,
chromosomal abnormality, you will go for amniocentesis, and most of those sex chromosomal abnormality, they are false alarm. Because if you look at the positive predictive value of NIPT, they are underpowered to pick up these sex chromosomal aneuploidy like monosomies or Klinefelters and all those.
Right.
They are underpowered because they deal with the prevalence, and prevalence is very, very low for these cases. But however, with genome-wide NIPT, many of the companies, they are throwing so many informations at you that once in a while you will encounter this kind of situations. And the best thing will be to reassure them and ask them to come at amniocentesis, and most of the time your reports will be normal. Okay, Ankur?
So
But
18 and 13?
18 and 13, always check the anatomy, which I showed you, do a detailed phenotype.
If
on
something
ultrasound,
abnormal comes up next,
then do CVS.
CVS.
If something abnormal comes out,
But
you
in
know,
13 there is as low, 22% mosaicism is there. So
is there. But suppose if something comes out like you get a median cleft, or suddenly you are saying that there is some features of holoprosencephaly. It may not be a very frank A-lobar,
but
maybe some kind of milder variants or semi-lobar or whatever. Then you know these are all pointing towards trisomy 13. You have an extra digits. Polydactyl is a feature of trisomy 13. You have some kind of, suppose rocker
Then I
bottom
know
and all,
ki
which are
I'll get
features
it
of
in the
trisomy
CVS
18.
itself,
Then you know the phenotype is matching with this report.
Hmm.
Now I just need to confirm that. So fetus is showing the problem. So those cases, the chances of being mosaicism is very low.
Very low. Okay.
So those cases you need as early confirmation as possible, because couple don't want to
Wait, of
wait
course,
unnecessarily.
there's no point,
But in these cases also, in real life, what happens, sometimes we face a situation like by the time they come and we find something is there and all those, it becomes like 14 weeks, 2 days, 3 days, all those. So those cases,
We can
call
go
them
for
back after
earlier
1 week and do an amniocentesis.
amniocentesis.
That is a better decision rather than putting needle that time to do CVS. But the same thing if happens at 12 weeks, they will not wait for 3-4 weeks. So you do CVS and you are justified in doing so. So do that. Now, are we ready for its application in twins? Okay, how effective is your NIPS in the twin gestation? That is something, Devalina, you were asking also.
So regarding all other screening also I was asking, like quadruple is not
We
validated.
will do.
Why
We will
not?
do. We will do twins separately. We will do.
Okay.
Now the question is how comfortable we are in NIPS when we talk about twins. I am not very great fan of doing NIPS in twins for the reason that it gives only one risk, and then if it is high risk, we don't know which baby, and anyway we have to do sample both the babies. And also there is very high chances of no calls in twins. But if you compare the detection rate and efficacy, still NIPT is far superior to combined first trimester in twins. So if somebody wants NIPT in twins, we don't have any rights to discourage them, because we will be wrong. Because all data now they support NIPT in twins, and they can go ahead with it. And even it is better for a monochorionic twin, because monochorionic, you know, most of the time the genotype will be same. So even though if they are getting one risk, it is good enough. For dichorionic, the problem happens because you know there are two separate fetus. It is two different individuals. But for monochorionic, it is just as cleavage related issues. So they will have only pregnancy specific risk anyways. But dichorionic generally have fetal specific risk. But NIPT gives only one risk. Now, if you see this, just a recap of what I showed you in the previous presentations. I showed you that all these dizygotics will be dichorionic, and monozygotics may have all these kind of presentations. And this zygosity or chorionicity issue, this can only be solved if you are using a SNP based technique where it deals with the fingerprinting. If you are not using SNP based, you will not get any idea on the zygosity. Then you are just dealing with the chorionicity related information. Now, if you look at here, your combined fetal fraction is 35% greater as compared to singleton. But overall their single fetal fraction will be less. So individual fetal fraction is 2/3 of the singleton fetal fraction. Okay, and for 4% cutoff, in twins you will have 22% no calls. For 4% cutoff I am talking about. That is why in twins for no calls, in singleton for no calls, generally the threshold is 4%, but for twins it is 6 to 8%. Because if they keep the same threshold for twins, then almost 1/4 of the cases they will say I cannot generate the report, which makes no sense.
So sir, for a obese IVF twin, it's no point going for an NIPT in those cases.
Then you have to explain them these facts.
Okay.
And the facts are best explained by figures.
Obese?
Twin IVF. तीनटे आलादा separate entity হয়ে গেল which will
Sir, if we do directly mention that SNP based method I have to do NIPT, then is it justified in twin?
SNP based মানে fetal fraction এর উপর তো depend করবে তো সেখানে তো
It will still depend on the fetal fraction. SNP will only be advantageous because it will tell you about the zygosity. But as Deblina is telling, it's IVF conception where we have understood IVF conception has got even increased risk of no calls. And on top of that, she's high BMI. High BMI is again a problem for generating the report. So all these cases, the chances of getting no calls will be monumental.
Got it.
so it's better to go for FTS
Best thing is go for a combined first trimester and then take decisions based on that. But you should know all these things. And always when they generate the report, the algorithm is adjusted to account for the lower fetal fraction of the twins. So suppose one fetus is having fetal fraction of 4%, other is having fetal fraction of 10%. So it will not be like 10 plus 4 divided by 2 is equals to 7% and then it will generate the report. No. The bioinformatics is set at a threshold of for the lower fetal fraction. So it will say, okay, lower fetal fraction is 4%. So I will not generate the report. I will not take the 10% into account. Just for the quality control, because we are here over conscious so that we don't falsely label them normal.
Right.
Okay. So this is all that issues about the twins when we are doing NIPS, and you have to discuss with the couple, and always it is better to discuss with the figures. हाँ रोज हम आ जाएगा, मैं क्लास ले रहा हूँ, हम आ जाएगा 15 मिनट 15 मिनट. So why I'm telling you this, when we are counseling the patients, they understand best with the figures. If we can quote some figures like this percent, that percent, they are able to better correlate. Now this is the detection rate and false positive rates in singleton, which we discussed in last class, and this is the detection rate and false positive rates in the twins. So it is not bad. It is 99%, 0.2% false positive rates. But as you come to trisomy 18 and 13, the numbers are very less actually in this cohort. 50 and 11. Why numbers are less? Because nobody interested in NIPT in this kind of situations. I'm extremely sorry for this. Sita is calling. Sita is here? Sita? Just a minute. Hello, Sita? Hi. हाँ बोलिए ना.